Hi everyone, thank you for coming to this workshop. I'd like to introduce you to Fraser Battye from the Strategy Unit. The Strategy Unit is a specialist NHS analytical team, and as well as being head of policy, he's also run some of their training programs. I'm just mentioning that in case that's of interest to you. So they do training programs on decision-making, critical thinking, strategy, and leadership. So do look out if you're interested. Now, we're hoping that this workshop is going to be an opportunity for quite a rich exchange of ideas and perspectives. And to that end, we'd quite like to make sure that the tables have got different perspectives within the tables. So can I ask you to put your hand up if you are a user of evidence as opposed to supplier of evidence? So that would be a local or national decision maker, policy maker, clinician, patient representative. Okay, have we? So we've got a couple of. Yeah, we've got a couple. So we've got a couple of tables where we don't have any. If there are several people who put up their hands at a specific table, would you mind moving to a table that didn't have any? So there's one there, Sarah. If you could put your hand up. And I think the table behind probably didn't have anybody either. Is that right? Oh, you got one. Yeah. Any other table that doesn't have any users of evidence? No. In that case, I think we're good. Thank you. Also, just to let you know that this session will be recorded and will be available afterwards if we can make it work with the workshop bits. Also to say that at each table there is a scribe who will be taking notes, and the purpose is that we're hoping that you guys will be able to bring some really thoughtful and interesting ideas that could benefit others as well. So we're going to try and bring those together after this session and see if we can put them into a written and published output. Nobody will be named, so please feel free to talk candidly if you so wish. Thanks very much, and I'll now pass on to Fraser. Thank you.
Microphone. Hello, you can hear me? No, you can't hear me. My shouting is atrocious. There we go, that's good. Thank you. You didn't mention Therese and I are famous. She underplayed this very slightly. If you go on the Health Foundation website, there's a blog out like this morning, so the timing couldn't be better, that we've joint written. So yeah, that's counting for me as fame. That's like a little local peak in a career of peaks and troughs. So what are we doing? We're going to look at this question of how rapid evaluation can help us navigate the digital maze. As Therese says, I'm Fraser, I'm the head of policy at the Strategy Unit. We're an NHS team, as she said, predominantly concerned with helping decision makers to navigate all the complexities of the decisions that they face through the use of evidence of many different types, including evaluation work. We've done a fair bit on digital, and I'm going to share some of the stuff that we've done. At the core of the theme of what I would like to look at is fundamentally the question of how people engaged in the supply of evaluative evidence collaborate better with people who are the users and the consumers of it. So I'm going to focus quite a lot of the session in that sort of territory. And the way I would like to run the session, which is partly why we were sort of shuffling you around to make sure that the tables are fairly evenly balanced, is I would like to do some things from here, but not very much, ideally, and then get you doing quite a bit, and then we're going to try to operate that as it's like a call and response thing, isn't it? So we're going to run it in that kind of way. And we're going to begin the shape of the session. We're going to begin looking at problems, then we're going to move on to potential responses to some of those problems, and then we're going to end on this question of how evaluators and the users of evaluation can better collaborate. So that's the way we're going to run this. Other things you need to know. You won't have spotted, I'm congenitally shy, by nature fairly herbivorous, and yet this is okay, bizarrely. So if we meet informally and we're having coffee and pastries, internally I'm terrified. The unstructured chit-chat doesn't do it for me, but this seems to be okay. One thing, though, in running sessions like this I've found is reliably agonizing, is when you're working on the tables and I want your attention back, partly for politeness, partly because my voice doesn't carry. I hate interrupting you. I can't bring myself to do it. But because of running many sessions like this, I've improvised. I have a bell. You're now going to be conditioned. So you're going to be on your tables talking. I'm going to want you back, and I'm not going to stand here impotently wailing, "Can I have your attention?" I'm going to do this. And at that point, you know internal agony is set off, as I stand here waiting for you. So because you don't want to inflict internal agony on me, because you're all good people, you're going to return your attention to me, and then the session will proceed. So there you go. I think that's what you need to know. We're going to get going. We're going to begin with a thought experiment. I'm going to give you about 15 minutes on your tables to do this. You can just figure out how to arrange yourselves on your tables. You're all smart people. Maybe you have one big conversation. Maybe you have several small ones. I don't know. And I'm not going to ask you for feedback every time. So however you arrange yourselves is how you arrange yourselves, yeah? Anyway, here's the thought experiment. I want you to imagine. Some of you won't have to imagine. You will literally be a decision maker in health and care. You're diligent, you're professional, you're always looking for ways of improving services, and you're about to implement a promising-looking digital tool. Now, you can make up, digital tool of your imagination. If you're struggling for imagination, maybe think about an app to help with patient self-management. Yeah, so there's an example. So that's you. You're planning, though, because you're good and because you've come to rapid evaluation conferences, you shouldn't just roll the thing out. You should do some quick test or some pilot of it before perhaps rolling it out across your service. So I'd like you to just discuss on your tables. You're this character. What questions have you got for this pilot, for this test? And what kind of answers would you like? But then also, why might it be tricky for evaluators to meet those demands? Okay, so that's comparatively clear, I'm hoping. I'm going to give you 10 minutes at that. So 10 minutes or so on your tables. I'm then going to ring the bell. Agony is set off in me, and you're going to return your attention. We're good? Okay, cool. See you in 10 minutes or so. You're good, thank you. Okay, I hope that was useful. I hope it's at least got you into the sort of territory that we're going to be moving into. I'm going to offer a few thoughts now, largely on that question. So I'm now going to fill you full of problem, or compound some of the problems that you've already generated, by just noting out a few difficulties and challenges that face the evaluator when confronting digital tools and so forth, and we'll just flesh some of those out. In doing that, I'm going to draw really quite a lot on a piece of work I did with Support the Health Foundation, looking at some of the downsides of the use of digital technologies in the round, in providing health and social care services, again, in the round. So it was a great bit of work. I really enjoyed it. And if you open it and look at the list of interviewees in the annex, you can see why I really enjoyed it. Some of the people in there were spectacular to interview. And it wasn't particularly about evaluation, but many of the problems thrown up by it were relate to evaluation. So I'm going to draw a little bit on that. So here are some of the challenges that I think we face. The first is, optimism bias is like so well known as a problem and a tendency in our cognition that it appears in the Treasury's Green Book. Which is not often a source of insight into the human condition, but it's so well known that the Treasury's bit of psychology is about optimism. And anyone who works in health and care, or anyone who's got access to the BBC website, will know that the resource pressures in the system at the moment are horrific, and therefore tend, I would say, to stoke optimism bias, and perhaps in the end it cashes out as wish thinking. It would be almost remarkable to think that there were people in the service looking for ways of improving things that were not prone to wish thinking at the moment because the problems are so great. And one reliable repository for wish thinking is new technology, because it's on one level indistinguishable from magic. So it may well be the off-ramp that I'm seeking. So it seems to me that creates a certain environment for evaluation, and no one in the evaluation world wants to be the spectre at the feast, do they? So it sort of sets some atmosphere for evaluation, I suppose. That's the first challenge, perhaps. The second is this problem of thingification and the associated problem of simplification. It was really interesting listening to Sonia and, I can't remember the other person's name on the panel, talk this morning. It seemed to me one thing we're in the hunt for when it comes to evaluating digital products is a sense of what the right analogy is. Do we think digital products like apps or something are more like drugs and devices, in which case we'd evaluate them in one way, and that's fairly well trodden, we know what evidence-based medicine looks like, and/or do we think they're more like service changes, in which case there's a whole other set of evaluation disciplines associated. So one question for me is, what do we think an app is, for example, and is there a tendency to thingify it, to try to say it's more like a drug or a device than it is like a service change? If we do that, we ignore the complexity of it. So anyone thinking about the use of an app for self-management or something like that must know that the app itself is complex. It's continually changing. They will be training on new data. The algorithms will be updating. Well, the format of the thing will be changing all the time. That's the life of an app. And it will be interacting with something that is continually changing. So my circumstances, my desires, my wish, my condition, whatever it is. That's an extraordinarily complex set of equations. So I'm wondering there's a tendency to thingify and to simplify, and I'm suggesting that's perhaps not the right way to think about these things. And then the final thing also touched upon this morning in the panel is, of course, the world that generates digital products is a commercial world, and that's good and that's wonderful, and that's where capital goes, and it gets R&D intensive, and we cough up all sorts of amazing, wonderful things. It does, though, mean that the evaluator is operating in an environment that is at least coloured by commercial incentives. And again, I think perhaps in combination with optimism, bias, and wish thinking, I think that does something to the atmosphere for evaluation. It definitely, having interviewed a couple of people for this work, it definitely does something when it comes to things like access to data, including even really quite basic data for evaluation purposes. I don't want to just pump you full of doom, so I thought it was also useful to think about some of the upsides for digital tech. At least the potential for the generation of data has kind of got to go through the roof relative to many other things that we might be evaluating in health and care world. I've got a friend who runs websites, and his ability to just run A/B testing on how effective websites are is incredible. So there are some tremendous upsides in play here too. There we go. There's another slightly more, it's not philosophical, but there's another sort of background factor I wanted to point to that came through the work I did on digital downsides that I just think evaluation needs to be a bit careful with. So I'm just going to tell you a little bit about that. You could think about requirements for care. When I was interviewing people for this project, it seemed to me there were different elements important within the care process that we could usefully delineate slightly. There are technical and transactional elements of care that really matter. So if I go and see my GP, I want to know that they are technically on top of things. Do you know what I mean? I want to know that they know some things that are technically specialist. And I would also like that interaction to be transactionally smooth. So those things seem to matter. I would also, though, like my GP to be relationally excellent, and I would like them to be able to take account of contextual factors important to me as a person, and that also seems really important. So, it's not that we want one and we don't want one, we want both, but if your needs are different, you have a different emphasis, it seems to me. So if your needs are relatively simple, what you might privilege is the technical and transactional components of care. So get me in, get it diagnosed, and help me to fix it. Whereas if your needs are ongoing, and they're more about the ongoing management of insoluble predicaments rather than the fixing of a problem, you might privilege the relational and contextual components of care. So if I have multiple long-term conditions, for example. Now, these things aren't either or. They're, of course, existing in some respect on a spectrum. You don't get to see that is an arrow. The thing in the middle is pointing towards the technical and transactional components of care. In the interviews I was doing, it seemed to me that digital did quite a lot to improve the technical transactional components of care, but it was asymmetrical. It could not do so much to improve the relational and contextual. I then wonder, entering into this territory as evaluators, it is far easier to measure the technical and the transactional components of care. The number of people running through something for a given set of inputs, for example, it is vastly harder to measure the relational and contextual components of care. So I also then wonder, you can see this arrow, whether there's a tendency of evaluation to zero in on some of the transactional components. So that was a few thoughts I got on the problems that we might face as evaluators and things that are going on in our environment when it comes to looking at digital. I now want to move on. You're going to get another 10 minutes on your tables, the rhythm of the session. So I've just rubbed your noses in despair, And you are now going to enlighten yourselves, and then I'll offer you a few thoughts as well. So we've got a set of problems in play. You have raised some on your tables. I've offered you some in my presentation. I now would like you to zero in on how some of those problems could be overcome using rapid evaluation approaches. I would like to know, for the evaluators of the world, what could you be doing, and what could you be doing fairly rapidly to help decision makers navigate this digital maze? And what could you be doing to usefully add evidence into the decision-making process, knowing that it's going to be comparatively rapid and knowing that it's going to be coloured by some of the factors that I've just pointed to as well? Is that okay? So I'm going to give you a little bit more than 10 minutes on your tables. We're then going to repeat the thing where I ring the bell and you attentively and kindly return your attention to me. So, cool. So a little bit more than 10 minutes on your table on those questions. Thank you. Thank you. Okay, so hopefully you've turned the corner. You're less depressed than you were 10 minutes or so ago. You've turned your own corner. I'm going to offer a few perspectives on the same question. I'm going to do so, first of all, with a little bit of an anecdote, but which I think might have a generalizable punchline, maybe, but you will help me work that out. And then secondly, with a slightly more sort of conceptual thought, which again, it feels like you're going to help me work out whether it's a decent one or not. I'm going to treat you guys as the experts in that respect. Partly, I should have said, my evaluation spurs were many years ago, and now they're firmly rusty. I've probably spent the first 20 or so years doing program evaluation. I haven't done any for 5 years or so. So all of this newfangled tech stuff is stuff I've not really got my teeth into. So I'm now going to treat you as the experts on questions of method and help me figure out whether my intuitions have got anything in them or not. So the anecdote then about the evaluation of tech, I'm going to anonymize it to some sufficient degree that no one knows what it is. It was done by a colleague, and the object of the evaluation was it's like a digital avatar nurse, healthcare professional kind of thing, situated in a sort of kiosk in primary care, or intended to operate in primary care. And the basic theory was that here I am the patient, tipping up in the waiting room. I have some time to kill. I'm now going to go and engage with this kiosk. It's going to take some basic measures off me, and then it's going to supply me with bits of lifestyle advice. And in any case, the time is, I'm saving a bit of clinician's time, and also I'm learning a little bit myself. So here we go. And it was novel and innovative and all the rest of these things, and full of promise. And the colleague of mine who was sort of running this bit of the evaluation was doing the field work. So, went along to the primary care centre to have a look at how our avatar was performing. And turned up and, announced themselves to the receptionist and said, "Hi, we've been talking. I've arranged to come and see you and talk to the staff, and I'm going to talk to some patients, and it's all about this digital avatar thing. Where is it? Where is the kiosk?" And the receptionist said, "Oh, and sort of blushes slightly, which is like data point number 1. And then says, "Well, we began faithfully testing this thing. I promise you, evaluator, we did. But it took up a fair bit of space in the, crowded waiting room you're now in. And it was a bit noisy, and some of the things it was saying were slightly personal sounding, and the old people didn't particularly like engaging with it, and mainly they're the people that are coming. And so we moved it, and it was there, but, then it went there towards the end of the corridor, and now let me show you where it is." So, takes my friend and wanders around the corner and, opens the door. And this is where the digital avatar has found its home. It's now in some not very sophisticated cupboard where, if a patient really pestered, they probably could get access to it to use it. And then, of course, the receptionist is like, "Well, okay, shall I line up some patients and staff for you to talk to about this thing?" And my colleague is like, she's an experienced evaluator and polite and a pro and all the rest of it, so she didn't say this. But no, we're done here. That's the evaluation. We're now done. And one thing that occurs to me in that story, which I'm wondering if this is generalizable, is the research technique that proved to be extraordinarily valuable was turning up and having a look. So really, really good, basic, empirical, descriptive work. There is no less sophisticated research technique than turning up and having a look. And I just wonder if there's something about turning up and having a look in the face of really quite complex technologies, and actually whether that is really able to tell you a lot from an extremely basic technique. I'm now conscious that my colleagues at the strategy unit do extraordinarily sophisticated things, and I'm in front of a room full of sophisticates. I'm not saying we should junk sophisticated method as well. I'm just wondering whether there's something about the basics that might actually be really important. My second thought was, and then this is why I apologise for my evaluation age. This is probably now old hat, isn't it? But the sort of 4 E's as a framework for thinking about evaluation. I know it more from sort of value for money type world, where we would concern ourselves with questions of efficiency. So, the rate at which we're converting inputs into outputs. Effectiveness, are we seeing the outcomes that we desire from this thing? Equity, are these outcomes reasonably distributed or are they maldistributed in some horrible way? And economy, could we have spent less doing the thing that we're doing? So that, basic set of 4 classic evaluation questions. And yes, it seems to me that the claims of tech are overwhelmingly dominated by efficiency claims. In the main, I would say that tech claims are about the ability to do more with what you have, or to do the same with less, or something like that. But predominantly the benefits of tech, I think, are concentrated in terms of efficiency claims. And again, so 2 things that follow from that, from my perspective. One is, I don't think as decision makers or evaluators we should ever allow efficiency claims to dominate all else. We will always remain concerned with things like effectiveness. Definitely we want to care about equity. So we are going to want to balance the set of questions. But efficiency is pretty basic from an evaluation perspective. If your basic tests are questions of efficiency, this is easy stuff relative to the stuff that normally gets us evaluators wringing our hands, effectiveness and what would otherwise have happened and how we're going to construct a counterfactual for this. So I'm also then wondering whether in fact the research response is a really quite basic one, and it's just looking carefully at efficiency claims made by tech. And again, that can be done in quite basic terms in research method. So they're my set of reflections. Mine's a sort of back to basics message. I want to make sure we have a conversation and we all get to hear what has gone on in the different tables. We have a little bit more than 1/4 of an hour left. Can I give you 2 minutes on your tables with a couple of questions and then bring you straight back and open the conversation out? That's basically okay? I'm going to give you 2 minutes on your tables super quickly. What are your conclusions? So here we are stumbling around in the digital maze in, more or less a state of confusion. What might this mean? What practically could we be doing as decision makers, as evaluators, but most particularly I'm interested in this question of collaboration for the way that evaluators and decision makers can operate together. So I'm going to give you no time at all. I'm going to ring the bell and then I'm going to open the conversation out from there. Okay, let me have you back. I'm now just interested in opening the conversation out because I've kept you on hermetically sealed tables thus far, so you've no idea what anyone else has said or thought about anything at all. Maybe you have comments, maybe you have questions, maybe you have thoughts that have emerged on your tables. Maybe there's some nuggets of insight that you've just hit upon in your conversation that you suspect others might stand to benefit from. So that's my open invitation for someone to put their hand up and then get us going. Yes, at the back.
Sorry, I'm not normally one to publicly speak, but I will just share some of the thoughts on this table. So I'm Judith Finn. I'm one of the leads in Health Innovation East evaluation team. So we are kind of embedded in this environment of balancing what the decision makers want, what the commissioners want, what the innovators want, and that commercialized environment in which we're trying to be an independent evaluator. And I think a lot of the discussion that we had here was about managing expectations, scoping at the beginning, and co-design, co-producing that kind of piece of work. One of the things that we talked about, one of the things that we do a lot of is developmental evaluation, where you are much more aligned to sort of quality improvement kind of change management approaches. So you're constantly feeding in, taking an iterative approach to both the implementation and the evaluation. So that's just a little sharing our views.
That's really excellent, thank you. So you're doing several things. You're both engaged in the task of trying to help the thing be better, so you're engaged in developmental evaluation type approaches, whilst also trying to traverse some of the environment I was pointing to earlier about the way commercial incentives might operate as well, so that's really interesting. And squaring those two things out can't be easy, because those two things, you could see them in tension, couldn't you? There'd be ways of understanding it that way too. I saw other hands flinch. Someone's going to go through with it. Yeah, down the front.
So sorry, it's very loud. Some thoughts from our table, maybe just summarising on that sort of final slide. Maybe starting with evaluators. Some sort of thoughts from our table was maybe that sort of point you raised around turning up and having a look. Evaluation being really well designed, sort of user-centered. So especially in that digital context, if you're moving from paper-based to digital, does that work in a resuscitation unit, for example, where it's so fast-paced, people will just not fill that in. So the turning up and having a look aspect and user-centered design piece. Also, in terms of the sort of rapid evaluation lens, probably just appreciating that there's an inherent trade-off. I actually didn't really know what rapid evaluation actually meant, but all the people on the table thankfully did. And so there seems to be a real obvious trade-off with, well, if you're doing a piece of evaluation that takes 2 months versus, a full-blown piece of evaluation, you're going to have trade-offs. So you can't just say, what can we do with rapid evaluation to make it perfect? That's not sort of the framing. There's a trade-off there. Using realistic frameworks and co-designing with users. So that's maybe in the evaluation piece. And then in terms of for decision makers, maybe a few points like improving commercial digital literacy, so that the procurement professionals actually buying the digital tech know what they're sort of talking about, and making sure that they're well aware. And then the working together piece for me, I think there's a bit around sort of scaling up, so evaluations that are maybe done in certain trusts. We've got a fragmented system, and if you want to leverage, systems that us in the department are leading on, like Compass, for example, scaling it up nationally, all these different procurement teams and all these different trusts will look at an evaluation and say, well, we're completely different. Our patient demographics are different. The size of our doors are different, so maybe we can't get that med tech in. Really good example was an evaluation done by NHS supply chain on Sharps bins. Fantastic bins, economy, fantastic, efficiency, fantastic. And then in orthopedics, I think it was an orthopedics ward, took them on, and they used massive needles for lumbar punctures, so it just wasn't, applicable. So for me, the bit around working together is maybe appreciating or thinking about how do we scale those evaluations so that they're universally recognized insofar as they can. So that's a few bits from me.
That's cool. Thank you very much. I've got a couple of thoughts then, I'll invite someone else. The first is the question of where to focus rapid evaluation attention in both of the comments and in some of what I was reflecting on, I suppose. Maybe these things are sort of early in the life of a product. Maybe we're doing quite rapid evaluation tests early on. We don't want to let it out into the wild until we've looked properly at safety or efficacy, those kinds of things. But much of what we've talked about I could see early in product development. And the question of being patient-centered when we do it, one thing I clocked in the digital downsides work that I pointed to earlier is the one tendency within digital is to perhaps be very efficient from the organizational perspective by offloading tasks onto patients. And so efficient from one perspective, but not necessarily efficient from a broader perspective. So I think there's an open question there of perspective. Anyone else? Hands up. Auction house style. Gareth, you don't get to do this. You don't know who's allowing a colleague to ask them questions when they're on the stage. That's not happening. Don't give it to Gareth. There we are. Thank you.
Hi, thanks. I'm Shubhra Kamat. Basically, my background is pediatric orthopedics, but now into change management and transformation in Kent and Medway. I mean, from our group, I think we had a bit of a drumbeat of two things. One is we are in an uncertain environment. I would describe it as VUCA, which is volatile, V for volatile, U for uncertain, C for complex, and A for ambiguity. So basically, in context of all of these factors, the first question was around decision makers. I think what we picked up is the most important thing is we are in a fragmented environment, and we are like, sorry, I don't know your name, but like you mentioned, in terms of the population and the group and where we are from North London to Kent, and when we are looking into a digital product, how does this work for each of the population? We'll probably never get that 100% correct, but actually having certain absolute standards would help, because something which is non-negotiable, such as, have we got the information correct? Have we got the evidence? Are we able to capture the voice of the patients? But what does this mean for the staff and clinicians? Accessibility is a big thing, and that is what our drumbeat was in terms of decision makers, but also not having it a tick box exercise, looking into the ever evolving and changing aspects and making sure decisions are made collaboratively. So that's for decision makers. In terms of evaluators, it was more around, have we co-created the product and making sure that it's back again with the clinicians, with the public, and all the places that we can't reach to, have we ensured we've got those people in the room from the beginning is the important thing. And does this work, and what is the impact and the outcome we are getting from it, and lessons learned and sharing practices and making those changes as we go. So these are the things. Anything else?
Don't give him the microphone. We've talked about this. Thank you very much. Thank you. The VUCA environment, you don't mean this place. This place is lovely. You just mean the world. Okay, I'm with you now. Your point about standards is a good one, I wonder. For many, many different things, including my clever avatar in the primary care, we could say up front what the standards are, couldn't we? We could say what the tests are, and they would include things like people find it acceptable, people use it, it's not in a cupboard, things like that. And we could quite easily look at these things, and we could also agree up front what decisions we might be taking off the back of that. So I think that's an important point. Okay, we don't have oodles of time left. I'm going to set the bar slightly higher. If you think on your table you've hit on an insight that might be more generally useful for the rapid evaluation world, pop your hand in the air. There we go.
Hi Fraser, it's Laura Yearsley here from the NHS Horizons team. Thank you so much for such a thoughtful conversation to take us through. Something that we talked a lot on our table was about learning and how we can bring in iterative cycles of learning that help us to meet people where they are, and to do that on an ongoing basis so that learning becomes the strategy. And something that we've developed in the Horizons team is an approach called Rapid Insight that allows us to do that. So it builds in this two-way feedback mechanism. It's very much connected to how we facilitate and design. And we have to make it really clear what's in it for the people themselves, and to make this a two-way dialogue so that it becomes meaningful and purposeful for the end user as well. And there's something for me about often when we're generating data and we're looking at the evidence, how we take a broad view of that, because often it's the things that are not said or the unheard voices who have the most interesting insights. But certainly working in such a complex space, we need something that is dynamic and that is flexible and that is feeding into an evaluation framework that helps us to make learning part of the strategy. So that was something we explored on this table, and I'm very happy to share more to anyone who might be interested.
Well, that's nice. You've outed yourself as someone who's got thought and experience on that, so everyone can now turn around and clock you as the person to grab at the break time. The point you're making, which is kind of the methodological territory you guys have trodden, is that in rapid evaluation we might end up with things that are almost indistinguishable from facilitation method, and much of the method that I know you guys have worked upon is ways of sort of gathering many voices and not systematically excluding some, and doing so fairly rapidly as well. So I suspect that's fertile territory for many of us. Thank you. Anyone else? Oh, there's two now, and look, I was ambiguous in the way I did this. So if you, there you are. Oh, are you being polite? You are now pointing at, no, you were being over, yes, you then. I don't know, it's not, you did this and then you were pointing politely at... You're both so polite. Shall I be impolite and say, do you mind going first?
Hi, I was just going to say I think there's also scope for doing rapid evaluation on the kind of metrics, like what's really difficult to measure. So kind of what you spoke about, the emotional, I think often we undervalue those aspects because they're really difficult to measure, and I think there needs to be a lot more honing in on those aspects specifically. And I think learning from other people how they're kind of dealing with the difficulties of measuring more qualitative aspects, and also just recognizing that they don't necessarily need to be generalizable in the kind of way we often think about in quantitative research, but more just analytical, and what does this kind of mean for different communities. I think, yeah, there should be more of a focus on that for there to also have more of the shift from efficiency. Also, we can tap at equity aspects in that respect. Yeah.
Well, that's excellent. I'm on your team. I'm pleased I forced you to not pass on the baton and to be polite. There's something really important in what you're saying, which does touch upon the relational and contextual elements of care that I was pointing to, which is that if you collar me over pastry or something and say, what's the most important thing in your life? I'm going to tell you about the love I have for my family, or something, something that is hard. And they, well, how do you measure this? How would you? And I say, I don't know. It's slightly ineffable. There must be some things in the relational components of care that are somewhat analogous to that. And what you're saying is that the evaluation world should strain itself to accommodate that rather than do the easy thing next door, which is to count the widget. Is that what you're saying? Excellent. Okay. Yeah. I'm very firmly on your team. Yeah, that's excellent. Thank you. And then here, and now you're waving it away. Okay. We're probably done. Yeah. We're done. Okay. Thank you ever so much. That was excellent. Thank you. Cheers. Oh.